I'm going to summarize this as two main things. I want you to associate volume with venous stuff, and I want you to associate pressure with kind of the arterial stuff, okay? And if I say atrial, I mean arterial. Okay, so venous system will determine how much volume we get into the left ventricle, okay? And the arterial system will determine how much pressure we need to generate in the left ventricle. Okay, so let's get started. Kind of a key point here is liquid is always going to go from high pressure to low pressure, okay? So here, liquid's moving this way, so we know this is lower pressure and this is higher pressure. So which side's lower pressure? This side, right? Just a dumb thing to think about, but do you think capillaries are bigger or smaller than medium arteries? They're smaller, right? So don't think that just because they're smaller, you know, you're going to have a higher pressure there. Pressure is always high to low. So your aorta is going to be kind of your maximum pressure after you generate it in the ventricle. Okay, what would happen if Doug, you guys remember this guy, King of Queens, didn't squeeze the ketchup bottle hard enough? Yeah, the ketchup wouldn't come out, right? So there's like some kind of inherent pressure that he needs to generate inside of this ketchup bottle in order to release all the ketchup. And that's a lot of ketchup for a burger. Okay, so here's the answer, apparently. The ventricle needs to generate a pressure that is higher than the aortic pressure to open the aortic valve. Make sense? So there's Doug with this ketchup thing. Here's a heart that's beating, and here we can look at the blue is the ventricular pressure, right? So it's low usually, and then it gets up high, and then it goes back to low, where the aortic pressure kind of stays up high, right? So when is the ventricular pressure the highest? During that systole part, right, where we're ejecting. So we need to generate high ventricular pressure to overcome the aortic valve. Right there. Right there. Not really big. So when does the ventricular pressure exceed the aortic pressure? Right? We squeeze, we generate, we eject. Right there. Whoa. That got big. So when is the aortic pressure higher than the ventricular pressure? Pretty much the rest of the time, right? And why is this important for valve function? Yeah, it keeps the aortic valve closed. Okay, this thing I want you to know inside out, and so we're going to walk through a whole bunch of it. What's happening at A right here? Yeah, the aortic valve is closed, the mitral valve is open, so we're beginning filling, right? So this is kind of our lowest volume state. Mitral valve is opening so we can fill in the ventricle. What's happening at C then? Mitral valve is closing. So this entire thing between these two guys is ventricular filling, right? So we fill up. This axis here on the X is volume. So as we increase, we're filling. So increased volume. Here, what happens to the pressure and volume during filling? Volume's increasing a lot, right? Because that's the whole purpose of this part. And pressure is able to go up just a tad bit, right? What's happening at D then? We've reached enough pressure to overcome the aortic valve to open it up. So kind of jumbled some words there, but I think you understand what I meant. So what's happening then at C? The mitral valve finally closes, right? So the mitral valve is closed at this point. The aortic valve is closed, and we're starting to contract. So there's no volume being added. We're just squeezing it. So this is isovolumetric contraction, right? We're generating pressure so we can overcome the aortic valve. So why do we move from C to D? The ventricle is squeezing at this time, right? Generating that pressure. What happens to the pressure and volume during contraction? Pressure up, volume, same. Okay, so what's happening at D then? We overcame, right, that pressure threshold, and the aortic valve opened. What's happening at F? We're done squeezing out. We reached what we wanted to reach, and the aortic valve closes to prevent that backflow, right? Make sense? Solid pressure thing. So then D to F is our ejection part, right? So volume is changing between these two because we're literally emptying out the ventricle. So what's going on with pressure? We generated a whole bunch of pressure here, and then we're decreasing the pressure a little bit here, and then we've relaxed down and then fill. Make sense? What's happening between A and C again? Filling. When do we call it systole? This ejection part, right? So when we're like moving it out. What's higher, end diastolic volume or end systolic volume? End diastolic, because moving from the systolic volume to end diastolic volume is the filling part, right? LOLOL. High end diastolic volume would mean that we fill the heart a lot, and systolic volume would mean that we didn't empty the heart out much. Make sense? This is Sean. Yeah.
From the, is it E to F? Yeah, from E to F, is that when the blood has the inertia? Or is that still all just contraction by the ventricle?
Yeah, I think that's, kind of momentum carrying it out. This is where you're generating all of it. You still keep squeezing, and then there's some inertia that's carrying it out. Because if you go back to that chart, there's a part where like the ventricular pressure is lower than the aortic pressure, but it still ejects a little more out.
Why does systole not start at C?
Why does it not start at C?
Because I guess we have such a high jump in pressure there. Wouldn't that be when the ventricles are squeezing?
This is when they're squeezing. Is that definition of, I'll have the definition written out there in just a second. We'll get to it. Okay, ready to move on? Totally different concept, but kind of still hard stuff. This is Sean. If you guys ever come to Boulware, he lays on the couch and just listens to lectures. This is Sean. So Sean's laying down because he knows that his lower body pulls blood when he isn't moving. Okay, why is this happening? Mostly gravity, right? The venous system essentially is this compliant thing that's going to store all of your blood. When you stand up, gets in the blood. When you lay down, you're going to have an increase in kind of the effective central blood volume. The other thing to note is when you're moving around, you're going to have these little valves in your veins, and you can squeeze up, right? So there's no like active movement other than these muscles squeezing it, pushing it up, and then to get blocked down. Problem these valves then would be, I don't know if you guys talk about it, but varicose veins would be a problem. Okay, so I want you to think of the venous system as just pooling blood for this part of the lecture, and we'll modify it a little bit in the next two lectures. Do you think there's more blood in Sean's venous system when he's laying down or standing? Standing. Right, there it's all going down because of gravity. Okay, what does orthostatic mean? Erect position, so standing up. What does hypotension mean? Low blood pressure. So then orthostatic hypotension would be low blood pressure because of erection of the body. Okay, this is Sean again. Sean's laying down, and his giant sacks of liquid are spilling out, right? So essentially his venous system is like putting the blood into the central blood volume. Okay, so when Sean is laying down, he has effectively more blood volume. What is going to change on the PV curve for Sean? So this is going to increase, right? You're going to fill more because you have more blood volume. So higher end diastolic volume. Sean gets loaded, okay? This is called preload. When Sean's laying down, he's preloaded, okay? Okay. What's another way? Sympathetics. Oh, are you asking them or me? Okay, you guys can go.
Increased venous compliance.
True. You don't see that very often from drugs that are great for doing that.
Would you want to squeeze your veins more to get more?
We don't have drugs that are good at doing that, so that's not a way that you can use fluids. So you use more fluids, IV fluids, you put them all out of the tank and increase the fluid that way.
You guys ready to continue? So what's happening from A to C? The filling, right? So this is being shifted out because we're filling more. We have effective more blood volume. So as Frank said, you can either have like more volume put in your blood, or your body is doing something to increase like the amount the blood that the heart would see. Okay, so stroke volume is the difference between these 2 points, right? On this volume axis. What's another way to say the amount filled minus the amount that's left in the ventricle? Stroke volume, right? Okay, so let's say Sean has hypertension. What does his left ventricle need to do now? It needs to push harder, so it needs to generate a higher force in the ventricle to overcome the aortic pressure. Make sense? So this is going to be an afterload effect. So here you're reaching up higher pressures so you can eject. So yeah. Pressure in the ventricle still needs to be raised above aortic pressure. So if we have increased aortic pressure, we need to generate more pressure in the ventricle. Afterload is the force that contracting myocardium must overcome. We just talked about that. This is a heart filled with liquid. Pump. Key points. So volume, venous, preload, right? So either decreasing compliance or laying down or having saline injected, increase in preload, increase volume. Pressure is like the either aortic stenosis or hypertension where you need to overcome a higher pressure. Okay, beta-adrenergic receptor stimulation increases how strongly the heart can contract. So that's contractility. So that's this line moving right here, right? Okay, what would aortic stenosis look like then? Taller. First of all, what is aortic stenosis before we get to it? It's a narrowing, right? So narrowing of the aortic valve. So is this an afterload or a preload problem? Afterload. So there you go. Higher pressure needed, we escape. Okay, higher preload will also increase how strongly the ventricle contracts. Okay, so essentially, it's like a balloon thing, and the more you fill it up, the more it can rebound out. Okay, basically, the sarcomere has an optimal length, and normally you're not there. Okay, so this is normal. Your sarcomere length is right here. This would be where the heart could squeeze the hardest. So if you fill more, you're going to move towards this direction. This would be a heart that would be too stretched out and wouldn't contract. This would be one that's kind of on top of each other and wouldn't contract that way. That makes sense? So you have an optimal thing, and if you increase preload a little bit, you're going to squeeze harder. Okay.
So what's happening for that phenomenon? That's what you see in your rotations.
Frank Starling? This is Frank Starling. Okay, we're going to skip this because it's just a review of what we did. But I like doing these during my review thing, so you can do them here too.
These are really good concepts to get down really well now because I'll show up again and again for your patients. And medicine, I just finished a month in the surgical ICU, and this is what we talk about for all the patients. This is like sort of how they're confusing all of their words. Is this concept of preload and afterload and kind of putting different drugs and get some modulate to those things. So learn it well now, people come back and get it again.
Ooh, okay, so we're moving kind of this way where we're emptying it out and we end up with end diastolic volume, right? So systole is when the ventricular heart muscle contracts and pumps the blood out of the chambers into the arteries, right? So we're generating pressure and then injection. And then the filling part is diastole. So diastole is the part of the cardiac cycle where the heart refills with blood following systole. Right? So it's not atrial contraction, right? It's filling. When do atrial chambers contract then? Kind of towards the end of the diastolic to like squeeze in a little bit more. Okay, why do we have a diastolic pulse pressure? Pressure pulse, diastolic pressure pulse. I don't know where it's going. Oh, yeah, this little bit right here. What's happening here? So the aorta absorbs pressure in systole and generates pressure in diastole. So essentially, if you think of this, hopefully this works. Maybe we can skip it. Oh, it's working. It makes funny sounds here. But basically, if you have a straight tube, you're just going to release it out in pulsatile manner, right? But if this can flex out, it's going to absorb some of that pressure, and it's doing that during systole. And then once this is closed, this is going to rebound back and then increase the pressure during diastole. Does that make sense? So it's kind of absorbing some of the pressure during systole and then giving you some pressure during diastole. Make sense? So look at this guy. Okay, as an individual ages, their systolic pressure increases, so that's the one during contraction, while diastolic pressure decreases, the one during filling. Why do older individuals have higher pulse pressures? So that's the split between the two. Okay. Let's think about what would decrease compliance of the arteries. I think there's a few answers, but one you covered specifically in lecture.
The elastin goes away.
That could be an answer to a different question. I think you can get that way with like regurg stuff, but
Compliance, because the elastin will pulls the artery together. So if the pressure change increases more volume changes more compliance. You get that with diseases like Markman's. You might have learned about
Yeah.
Markman's, it's important genetics, and the others on them. Those guys get aneurysms or big dilations of the aorta because they lose their elastin and they're too compliant. The rest are the opposite here. So it could be the opposite.
let's say he smokes and what else he's got? High cholesterol. Cool, yeah, atherosclerosis, right? So now he's got these stiff arteries and the blood's just shooting out, right? So it doesn't get absorbed in systole. That's elevating systolic pressures. And then we don't have that rebound effect for during diastole, so now diastolic is going down. So you see the widened pulse pressure there? Okay, this guy will come back. Hypertension increases perfusion of blood out of vessels. So you can imagine if you have high pressure inside relative to outside, you're going to want to move out. Okay? Okay? Whoa. Giving away all the secrets there. Increased protein outside of the capillaries. There's kind of increased junk outside of the capillaries. We'll also want to draw the liquid out. Kind of a rule you'll always hear is water follows salt. That's one way to think of it. But basically, oncotic pressure is what you're thinking of. So if you have a bunch of stuff on the outside, the liquid's going to want to follow it. So those are the two things that are going to drive liquid out. So here's what so why do you think we get edema then? Yeah, kind of those two things we just talked about. Protein in the capillaries, or just stuff in the capillaries being lower than the stuff outside. That's going to be your oncotic pressure. And then pressure in the capillary, like the hydrostatic pressure, being higher on the inside of the capillaries relative to the outside, will push it out. High to low. Starling's law of capillaries combines hydrostatic and oncotic pressures to determine fluid movement. So this is kind of going to be the equation of what we just talked about. So there's net fluid movement, right? And it's going to be these two things compared to these two things. So let's look at them. And K, for your purposes, right, you can just ignore. It's just a coefficient. You always care about the changes of things, relative, right? So this purple part right here is filtration. So these are the components that are going to make you move the fluid out. So this first part is the hydrostatic pressure that's inside the capillaries. So high hydrostatic pressure inside the capillary moves out, and then the oncotic pressure outside of the capillaries being high will draw it out. Make sense? And then reabsorption to move fluid in is going to be opposite. So hydrostatic pressure outside of the capillary, push it into the capillary, and oncotic pressure, so a lot of things inside the bloodstream itself will draw the fluid in. Okay? So why do we get edema with heart failure? Short answer is because of increased capillary pressure, right? But remember, I always said things go from high to low. So let's think about that. Oh, look at this. I made a slide just to make that point. Remember, fluid moves from high pressure to low pressure, okay? The tube thing. Okay, heart failure can back up the venous system, leading to edema. So let's say you have your feet here. Through the venous system, they're going to get back into the right side of the heart, right? So this is the direction of blood flow, so pressure must be decreasing this way, right? Okay. In just a second, I'll tell you that right atrial pressure for a lot of things you can just assume is zero or negligible. So let's say we have a problem on the right side of the heart, and there it is. That's my X for a problem. So an increase in pressure in the right heart. So we're increasing filling pressure because the heart's problematic or whatever. So what does that do to the venous system? Then we have to increase sequentially back, right? So there's like a backup of everything. So an increased pressure in the venous system as a result, because blood flow wants to move from high to low, and then increased pressure in the capillaries is going to make the fluid leak out. That make sense? So another way to think of it is like the number one cause of right-hearted failure is left-hearted failure. Can you imagine why that would be? You're doing kind of the same thing, but through the lungs, right? So problem filling up the left side, backs up, you need higher pressure in the lungs, you get edema there, it could be a problem for the right side then, and so on. Make sense? Everything backs up. So here's the heart. 3 things needed to make it beat. Food, water, and compliments. Thanks. Here's another heart. So this is going to be regulation, dynamics, and reflexes, 13 and 14. There's my heart. Okay, what do bears and this 14-year-old boy with terrible social anxiety have in common? What if I say beta 1? I don't know, their heart rate's probably going crazy. Just saw a bear, you want to run away? Except not these bears, because they're from We Bear Bears, and it's an awesome show. This is me when I was 14, sitting outside of my trailer, my first day of work at Culver's. Yeah, I was terribly shy, and my heart would go crazy. So beta 1, right, adrenergics, that's going to be sympathetic activation, increased heart rate, or a decrease in parasympathetics to increase heart rate. Run away from the bear, interact with people abnormally. Okay, why is flow always from higher to low pressure? Well, here we go now, okay? So flow the rate of flow, or the flow is going to be the difference of the pressures, upstream minus downstream, over the resistance between them.
Have you seen this before? Yeah, exactly.
So we're saying upstream, downstream. What would happen if the downstream things had a higher pressure than the upstream things? You're just going to flip the flow, right? So you don't want to do that in your body. What's R? R is resistance. So how difficult it is to get from one place to another. So radius is the most important part, or most important determinant of resistance. So let's look at the equation for resistance. Here we have resistance. Here we have length, viscosity, and the radius. What's special about radius? This number right here. 4th power. So that's why it's the most important determinant of resistance. So what's this thing? Here we go. Come on. What is this? Muscular artery, IEL. Sorry, I snuck some histo in. Okay, why is the radius important? Well, resistance, why is it important to resistance? Why is the most important determinant? 4th power. Okay, how does radius change from aortic capillaries? Bigger to smaller. Does gaining weight change resistance? Yeah, which way? Why would it decrease? So let's say there's no change in the actual artery architecture. You're just gaining weight and you have to increase the amount of vessels that you have to deliver to new tissue. That make sense? Okay, so it increases in length. Okay, how do you think anemia would change resistance? Viscosity, correct. So what is anemia doing to viscosity? Decreasing it, right? So you have less stuff in blood. So a decrease in resistance because of a decrease in viscosity. So there's a length increase, there's that L right here, right there, and a viscosity right there, right there. It's also important to note what's the numerator, what's the denominator, right? Okay, so what happens if we move to the top of a mountain? Let me illustrate this. So here's our school, right? Here, nice summertime here, and then we move to a mountain, meaning we have a change in altitude. Here we're going up high on top of a mountain. Get ready for some pictures of me. I love myself. Here's me, all happy because it's sunny. And then here's me. Well, I got a nice amount of blood here, okay? Just enough to survive. And then here's me with some frosty tips right here or something because it's super cold. I don't know. I think Superman with the crystal thing was inspiration. Anyway, now I have a ton of blood. What's going on? Why do I have it? What will happen with what will high altitude do to resistance? And the hint here is a whole bunch of blood. Increases. Why does it increase? Because now we're doing the opposite of anemia, right? So increase in viscosity with polycythemia. What is the change in flow if we double viscosity? That's just making it easy here. So let's think about what happens to resistance first. What happens to resistance if we double viscosity? 2 times increase in resistance. And where was resistance in flow? Yeah, so decrease in flow. What was the biggest contributor to resistance again? Radius. 4th power changes, right? What is the change in flow if we double the radius? So 16x change in resistance, 16x change in resistance leads to 16x increase in flow. Back to this guy and his narrow arteries. Okay, so let's say this guy had a 50% narrowing of artery X. How does this change blood flow in artery X? So now you're decreasing radius, right? Is that an increase or decrease in resistance? Increasing resistance, so these are halves, right? So half times half times half times half, now it's a 16th change. So a 16x increase in resistance is a 16x decrease in flow. Cardiac output is flow that is determined by pressure and resistance. So that same equation we can apply to cardiac output, okay? So there's flow, flow is cardiac output. The pressure upstream is the mean arterial pressure here. Pressure downstream is the right atrial pressure, okay? And then resistance is the total peripheral vascular resistance that we have here. And now remember I said the right atrial pressure for our purposes is pretty negligible, right? So then our equation becomes cardiac output is approximately the mean arterial pressure over the total peripheral vascular resistance. Okay, Reynolds number, back up. That was talking about quantity of flow. So we just described the quantity of flow. Now let's talk about quality of flow a little bit. So Reynolds number describes the degree of turbulence in flow. And there's the equation there for the questions that I'm going to ask. So essentially, we have nice linear flow here, a laminar flow, and then we have this very odd flow here that's very turbulent, right? So higher number of Reynolds associated turbulent flow, lower number is associated to laminar flow. So is A or B more turbulent? B. Higher turbulent flow is seen with high velocities. Okay, so the higher the velocity, the higher the flow. Hint, there's going to be a question about that next. Another thing that can increase turbulence are branch points, so a place where arteries are going to kind of bifurcate and split apart. So then stenosis as well. So narrowing of arteries can increase turbulence distally. Okay. What about anemia? Back to anemia. Will it increase or decrease turbulence? It's going to be like a 3-step question. So it does increase turbulence, but what does it do to viscosity first? It decreases viscosity, so that means it's going to increase blood flow, so a higher velocity is going to be more turbulent. So there's velocity, and then here also we have viscosity, so decreased viscosity, increased velocity. They both point to increased turbulence. Okay, higher turbulent flow is seen with higher velocity of flow. Essentially, nice even stream is Patrick in this little T thing, and highly turbulent flow is going to look more like this. Okay? You can skip this, but it's nice to go through it on your own. Okay, you don't want to poop. Wait, you do want to poop sometime. You don't want to run and poop. You want to run then poop. Okay? So we're going to talk about sympathetics and stuff. So exercising muscle will dilate vessels to get more blood through. This is active hyperemia. So just the act that your muscles are exercising or doing something is going to produce vasodilator metabolites. So these are potassium, adenosine, prostaglandins, nitric oxide, and hydrogen peroxide, right? So they themselves are going to increase, they're going to decrease vascular smooth muscle tone and dilate the arterioles. Okay, so there they are, opening them up. What happens to the radius if we dilate the arterioles? Radius increases, so then what happens to the resistance? Decreased resistance, and then what happens to flow? Increased flow. So if we exercise, release metabolites, we want to increase flow. Everything's up and down, Austin. Barriers to blood flow prevent vasodilators from being washed away. So if you have something occluding us, the vasodilators are going to start piling up, okay? So what happens to vasodilating metabolites in an occlusion? They're going to accumulate behind the occlusion. If area X is less perfused than an area Y, which one's going to have a higher concentration? The one that's less perfused, right? So X has more buildup than Y. Our goal here is to essentially try to dilate them and get over the occlusion. Body sensing something's wrong and is trying to do something about it. What happens when we don't wash away the metabolites? Accumulation of vasodilators decreases vascular tone to increase blood flow through decreasing resistance. Occlusion, blocked blood flow, so metabolites accumulate behind occlusion. What do the metabolites do? They decrease vascular tone, hopefully release the occlusion, and there we have increased blood flow. This is called reactive hyperemia, where the previous example with the exercising muscle was active hyperemia, right? Okay, one more example, a couple more examples of accumulation of vasodilators decreasing vascular tone to increase blood flow. let's say there's a transient decrease in blood flow that's associated with a decreased arterial pressure. What's happening with the vasodilating metabolites? They build up, right? Very, very similar to the occlusion thing we talked about. So accumulate, vasodilate, and increased blood flow returns us back to baseline. There's a transient increase in blood flow that's associated with an increased arterial pressure, increasing arterial pressure, so the vasodilating metabolites are going to be moved away. Make sense? So what is it going to do? Vasoconstriction. So unaccumulate, vasoconstrict, decrease blood flow. We're always trying to get to baseline. Body's trying to fix something that you're doing wrong. Arterial pressure increases. Arterial pressure increase will stretch vascular smooth muscles of arterioles. The stretch itself has associated calcium increases that lead to contraction. What does contraction do to the radius? Decrease. So small radius means high resistance, which means smaller flow. Okay, nitric oxide is neat. I would know it because it's neat. So what's happening here? Blood's flowing through, it's tugging on the walls here, and nitric oxide is going to be released. So increased blood flow will tug on the walls. Blood flowing through says, come with me to the walls. But the walls are like, I can't, I'm stuck here. Clearly, this is a very stressful situation, sheer stress. I need a break from you, say the vessel walls, as they summon some nitric oxide, right? They're like, oh, I need some relief. Isn't that neat? What does NO do to vasculature? Vasodilator. Isn't that neat? Yeah. So just a summary. Increased blood flow, increases shear stress, vasodilate because of NO. Activated platelets and injury set your vessels smaller. So he didn't talk about too much about some of your vasoconstrictors, but in general, kind of if you have injury somewhere in your subendothelium exposed, your body's going to try to vasoconstrict real quick. So here are the 3 examples he give you for vasoconstriction: serotonin, endothelin, and thromboxane. That's about all I got for that. Okay, skip this. You can do it on your own. Here I say, so that's all like local stuff, so things that's happening immediately, right, at the source. Here's extrinsic control of flow, and that's going to be mediated by sympathetics, humoral factors, and then parasympathetics kind of exist. Okay? So going through the sympathetics, you have norepi at postganglionic terminals, and then you also have this part from the adrenal medulla where you have a presynaptic thing directly stimulate the adrenal medulla to release norepi and epi into circulation. That's kind of humoral too, right, because you're just throwing it out and circulating. But the receptors are kind of what is going to help you understand things a little bit more. So beta 1 in heart is going to increase heart rate and increase contractility. So squeeze harder, move blood faster, sympathetics. That one makes sense, right? Beta 2 in vasculature is going to vasodilate. So you're like opening it up, delivering more blood flow. That makes sense too. The one that doesn't kind of make sense is alpha in vasculature was going to vasoconstrict, right? So usually you don't think about sympathetics wanting to constrict your vessels, but they're going to, right? Because your goal is to deliver blood to the right places, not just increase delivery of blood, okay? So overall effect of sympathetics is actually an increase in vascular resistance and a decrease in venous compliance, which doesn't make much sense if you're trying to run away from a bear. But if we add in the local factors, all of a sudden those local metabolites that are working out are dilating way more than you would have decrease in vascular resistance. So the blood is getting to the right places and not going to the wrong places. You don't run and poop, you run then poop, okay? And the distribution of the alpha 1, alpha 2, and beta 2 is going to be different in different tissue. Make sense? So how does the decreased venous compliance alter the central blood volume? Let's think back to Sean. So you decrease venous compliance, you're squeezing the veins up, increase in blood flow, in central blood volume. Okay, so this other thing here to look at is what I was saying, the receptors are expressed in different amounts in different places. For example, skin is going to get a lot of nerve stimulation from the sympathetics, whereas the brain is not going to be affected by this too much, right? And skeletal muscle, they're kind of in between. So I said the skeletal muscle is kind of getting this vascular resistance increase, right? But the ones that you're working out or using are locally vasodilating, so it's a net vasodilating effect to the tissues you actually want to use. Make sense? So here's that comparison. I'll skip through it. Humoral, one more humoral factor to add. But before we get there, I like having little landmarks, because some of this blood stuff, the control, really doesn't make sense at all until it all makes sense. You know what I mean? So I like having little landmarks to remember. What do ACE inhibitors do? So their net goal is to decrease blood pressure. I think you can remember that from the CBL case, right? Okay. So drugs that block the renin-angiotensin system, like the ACE inhibitors, decrease blood pressure. So what do you think RAS does normally? Elevates it, right? That's one way I like to think of it. Little landmarks of things that you learn throughout. So, okay, what does renin do? Acts on angiotensinogen to give you angiotensin, right? What does ACE do? ACE goes 1 to 2, and where's it at? In the lungs. Okay, so what is the effect of having renin released then? Through a few other things that are happening here that I kind of whited out, just for simplification, we're going to lead to vasoconstriction, increase in blood pressure, and we're also going to try to retain salt and absorb more water, okay? Water follows salt. Humoral, one more thing, vasopressin is released from the hypothalamus to vasoconstrict with three main things. And here they are. High plasma osmolarity, low blood volume, and low blood pressure. Make sense? Retain salt, pull in water, fix everything. Parasympathetics exist, so they barely do anything here, right? Other than just work on the heart directly. So what's the neurotransmitter at the postganglionics of acetylcholine? Decreased heart rate and decreased contractility. That's kind of the main thing I want you to take away from parasympathetics. They'll do a couple other things like changing AV conductance, but very, very limited influence outside of the heart. So when you're thinking about total peripheral vascular resistance in your what's happening here or there kind of questions, just think mostly about sympathetics and that local stuff that we talked about. Okay, so brain, heart stuff are going to be a little different. They're special. Ventricular contraction compresses coronary vascular. So during systole, when you're squeezing the heart, you're pushing out blood, right? But you're not delivering blood to the blood right away. That's going to happen during diastole. That makes sense? So you're squeezing the blood vessels that are in the heart. It's like a sponge. It doesn't absorb very well when you squeeze it, but then when it relaxes, it's going to pull in. You also kind of have that rebound effect, right? That's most prominent during diastole. So the coronary ostium are going to receive blood flow during diastole. Coronary steal. Know this. Okay? Okay. Brain vasculature is super sensitive to changes in CO2 and a little bit to O2. So increases in arterial CO2 are going to cause cerebral vasodilation to increase blood flow to the brain, and then decreases in O2 will also cause cerebral vasodilation to increase blood flow. So I like to think of this as decreased breathing. With decreased breathing, you have more CO2 and less O2. Your brain's going to be screaming, saying, I want more blood. Okay? Okay. Some more fun questions for you to review.
Quick question, hyperventilation, is that increased CO2 then?
Hyperventilation, you're going to do the opposite. Yeah. So a lot of breathing. We'll talk about it next week, I think, during POEM, yeah. Okay, so now we're going to talk about reflexes super quick, hopefully. Reflexes respond to acute changes, okay? You have arterial baroreceptors that are going to, as bar would indicate, regulation of blood pressure, and then cardiopulmonary for regulation of blood volume. But it's kind of hard to separate these two in a lot of situations because an increase in central blood volume will increase cardiac output, which is going to increase blood pressure. That makes sense? They're very interrelated. We're going to look at them separately and then combine them. So increases in arterial pressure and blood volume stretch baroreceptors, making them fire faster. So they're always firing, but a more stretch, make them fire faster, less stretch, fire less frequently. So here we go. Stretch receptor fires at a normal rate, letting the body know everything is okie dokie. Stretch increases, faster firing. Stretch decreases, less firing. Okay, so you get this triple response from decreases in the stretch receptor. So let's first look at parasympathetics. Does it make sense that parasympathetics would go down? So your body's like, okay, you're not moving enough stuff through here. I can sense that because I'm not stretched out enough. Let me compensate with an increased heart rate, right? Squeeze a little bit harder, and then that's kind of the main thing here. But remember how I said parasympathetics don't really do much besides change heart rate, right? So they decrease the heart rate, so we decrease them to increase heart rate. So decreases in blood pressure make us want to shut off parasympathetics. If parasympathetics are decreased, what do you think is going to happen with sympathetics? We usually pair those together, right? Compare, contrast kind of things. So sympathetics, are we activating those in response to low BP? Yeah. sympathetics are then elevated because sympathetics are going to cause an increased heart rate. The two main things that I told you to remember, vascular resistance, decreased venous compliance, squeezing a little bit harder, it's going to go with the increased heart rate, and then effects on renin that I talked about briefly. Activation of which receptor makes the heart rate go up with sympathetics? That was beta 1, right? So norepi going to beta 1 makes you squeeze harder, it makes your heart rate go up. What else did beta 1 do other than increase heart rate? You squeeze harder, increase contractility. What was the overall effect of sympathetics on resistance? This was the odd one, right? So it actually increases. And then the decreased venous compliance. Sympathetics also activate the renin-angiotensin system. Why do we want to keep sodium here? Water follows salt. So if we keep sodium, we keep water, we're increasing blood volume. So here we go. Increased heart rate, increased contractility are going along with the norepi at beta 1. Then we have increased vascular resistance and decreased venous compliance are kind of our net effects of the sympathetic system. Increases in renin and are going to be kind of this whole bit right here, water follows salt. And then the last little bit is AVP or ADH or vasopressin or whatever other name you want to throw at it. Those are all the same thing. So increases in AVP are going to do kind of similar thing here. We're trying to resorb as much water as possible, which makes sense, increased blood volume. Okay, what were the three things that made us release vasopressin? Yeah? Two more.
Decreased blood pressure.
Yeah. Feel free to cheat, it's on the board.
Yeah.
Low volume. So low BP, low volume, high serum osmolarity. What do you think happens when the baroreceptors sense an increase in stretch? So this is the opposite. We're not going to work through this, and you don't need to either. So just memorize one, the one that makes more sense to you, whether it's the one that I presented or this case, and then just flip all of the arrows. Okay, so we can skip this. So sympathetics are decreased, but you should go through this on your own, see if it makes sense. But just memorize one, flip everything else. The one that makes more sense to you. You don't need to do the one I presented. So let's go through the blood flow now. So decreases in blood flow decrease the stretch and activity of the reflex receptors, right? So here we have a decrease in central blood volume, which is going to increase sympathetics, which we already understand why that's appropriate, right? And increases in vasopressin. But remember I said that they are interrelated. So a decrease in central blood volume is also going to decrease cardiac output, which is going to decrease arterial blood pressure, and bam, we just have this same thing again, right? So this is the integrative approach. Okay, so sympathetics, these are kind of the same thing, right? If you look at it, you only need to understand one. That's why I'm saying, it doesn't really make sense at all until you understand all of it. Okay, there's vasopressin. And then these are just little things that I stole from BRS that you can test yourself with. So kind of up, down arrows. And there's Sean again. There you go.